Hello, and welcome to the Foundation for Sarcoidosis Research Education Webinar on Skin Sarcoidosis. I'm Mindy Buchanan, Director of Patient Programs with Foundation for Sarcoidosis Research, and I'll be your moderator today. First, I'd like to thank our sponsors, Mallinckrodt Pharmaceuticals, for their generous support of our awareness and education programming throughout the year. And next, I want to go through some housekeeping. So this is a webinar, so we will not be able to hear or see audience members. This means if you use the raise hand function, we'll not be able to respond. That chat feature works only as a direct message to the speakers and moderators, so feel free to use that if you'd like to chat with us directly. I will be able to chat with you, the audience, and that's where I'll add any links discussed during this session. We'll also send out the links in the post-event email. You may send your questions throughout the webinar, either through the Q&A feature or in the chat. You have the option of submitting questions to the Q&A feature as anonymous if you'd like. And the chat is only, again, seen by myself and our expert and will not be seen by the audience. If you have any technical difficulties, please chat me directly and I will do what I can to help. It's now my pleasure to introduce our expert for today's webinar, Dr. William Damsky. Dr. Damsky is a physician scientist who uses basic and translational approaches to understanding mechanisms of skin disease. In clinical practice, he specializes in medical dermatology and dermopathology with a special focus on cutaneous granulomatous disorders, sarcoidosis, and granuloma annulare. Dr. Damsky is an attending physician at Yale New Haven Hospital, Yale Health Center, the VA Veterans Hospital, and Cornell Scott Health Center. He provides care for patients with all dermatologic conditions and has a special interest in sarcoidosis. With that, I will hand it over to Dr. Damsky and welcome.
Great, Mindy, thank you so much for the kind introduction, and thank you to everyone that's tuning in today. Let me share my screen. Okay, super. Well, it's a real pleasure to be here today to speak to you. I'm a dermatologist at Yale University in New Haven, Connecticut. And I have an interest in cutaneous sarcoidosis. And so I treat patients with cutaneous sarcoidosis, and we have a research interest in sarcoidosis in general, and as a dermatologist, particularly in skin manifestations of the disease. So I suspect this disease needs really no introduction in this forum, but I did just want to introduce a couple things. So sarcoidosis is an inflammatory disorder caused by inappropriate activation of the immune system. And so this leads to formation of what are called granulomas, or aggregates of a specific cell type called macrophages in affected tissues, which can include any organs that may be involved. These granulomas in the organ may impair function either directly or indirectly, and that's how they manifest in patients, and that's why we like to treat them as physicians. And so most commonly, sarcoidosis involves the lungs. The heart can also be involved. And as a dermatologist, I'm most familiar with involvement of sarcoidosis in the skin. Importantly, when we talk about involvement of an organ by sarcoidosis, we're talking about these granulomas in the affected tissue, whether it's skin, lungs, heart, or another organ. And I'll come back to this. And so what is cutaneous or skin sarcoidosis? Skin sarcoidosis is direct involvement of sarcoidosis in the skin tissue. This results in the formation of a visible rash. When the skin is involved, it may help in the diagnosis of sarcoidosis in other organs, which may be more difficult to biopsy or obtain tissue from. We know that skin is involved in about 1 in 3 patients that have sarcoidosis. And in some cases, skin rash may be the first symptom noticed by the patient, leading to a diagnosis of sarcoidosis. So what does cutaneous sarcoidosis or skin sarcoidosis actually look like? Well, in dermatology, we have a couple what we refer to as great mimickers, and sarcoidosis is one of them. And what this means is that the appearance of sarcoidosis in the skin may vary widely from patient to patient. This may result in a delay in diagnosis. Ultimately, to diagnose sarcoidosis involvement in the skin, we use a couple different things. One is, as dermatologists, we use what's called the clinical presentation, or just what the rash looks like, where it's involved, what it looks like on the skin. And we also may use a technique called skin biopsy, where which I'll talk about a little bit later, where the skin is actually sampled and we look for those granulomas under the microscope. It's also important to recognize that many rashes in patients with sarcoidosis are not a specific manifestation of the sarcoidosis. And we know that patients with sarcoidosis have an increased risk of having other types of rashes, and we'll come back to this. So what does quote unquote classic sarcoidosis look like? Well, here's an example of skin involvement in a patient with a lighter skin tone. And we see these red to deep red color of the rash involving the skin. And if we were to biopsy this in order to try to make a diagnosis, we would see these granulomas, and you'll see that to the right of your screen. And granulomas really are these collections of macrophages in the tissue that really are a hallmark of this disease. And so when there's specific involvement of the skin and we perform a biopsy, we see these granulomas in the skin. If we're looking at lymph nodes or lungs or heart or bone or liver or other organs, we'd see these same granulomas, and that's really how we diagnose sarcoidosis. And so if we want to make a diagnosis of cutaneous sarcoidosis, that's what we're looking for in biopsy. Here's an example of another sort of typical or classic presentation of sarcoidosis in patients with darker skin. Sarcoidosis is somewhat distinct in that it forms what dermatologists refer to as annular lesions. And so when we're talking about annular lesions, that means that the edge of the rash is a little bit more raised and looks a little bit different than the rest of the rash. And so here you can see that sort of annular look demonstrated quite nicely. Particularly in patients with darker skin, the color of the rash can vary. And so as in patients with lighter skin, we saw more red tones. In patients with darker skin, we may see more brown tones or even purplish or violaceous tones. And something worth covering is this term lupus pernio. This is more medical jargon, but you will come across this online. If you look at it, it can actually be kind of confusing. So this is an older term. Lupus, of course, is an autoimmune disease, which is distinct from sarcoidosis. And so if you have lupus pernio, or a dermatologist says you have lupus pernio, or you read lupus pernio term in your chart, it doesn't mean that you have lupus. It means that you actually have this particular manifestation of sarcoidosis, where you have these skin lesions or rash around the nostrils. And this may be associated with involvement of the airway as well. And so dermatologists may use this as a sign to suspect that and evaluate patients further. Sarcoidosis, unfortunately, when it involves the skin, not uncommonly affects the face. And really, sarcoidosis, whether it's on the face or whether it's on other parts of the skin, can have a huge impact on the quality of life. And, you know, I have a lot of patients who we talk about things like confidence, interpersonal interactions, ability to go to work, ability to go to school. Sometimes people think that you may have, you know, an infectious disease, which is clearly not true. You may have symptoms related to your sarcoidosis, and ultimately skin involvement of sarcoidosis can result in your happiness. And so as dermatologists, we're very accustomed to treating rashes. Of course, most diseases that we treat as dermatologists do not affect other organs as sarcoidosis does. And we find that in our interactions with other specialists that it may be not uncommon that skin manifestations are dismissed. It's unfortunate. And of course, there are important medical implications of having sarcoidosis in your lungs and your heart, which are important motivators for treatment. But skin is also important. And so I really want to make that point. And so if you have sarcoidosis in your skin and it bothers you, that is something your doctor should know, and that is something that should motivate the treatment that we use. And we'll spend a lot of time talking about treatment. And really, it's okay to push your provider to treat your skin. You know, the lungs may not need treatment, for example, but if your skin bothers you, it's okay to seek treatment for that. And we'll come back to this again too, but I wanted to introduce that concept. Sarcoidosis is sort of scientifically interesting in that sometimes it involves tattoos. Interestingly, although not really pictured here well in this picture, sarcoidosis prefers certain colors of tattoo ink, classically red and yellow. And importantly, some patients may initially present with sarcoidosis within a tattoo. And we often get the question whether or not these patients need evaluation for other manifestations of sarcoidosis in their body. And the answer is yes. And so it's not that the tattoo is causing sarcoidosis, but we think about it more as the tattoo may be unmasking the sarcoidosis. So it's bringing it to clinical attention. Sarcoidosis also likes scars, so it likes to come out in areas of scars. And so this patient on the knee has, these sarcoidosis lesions, but they're also involving this linear scar here. And so when dermatologists are evaluating patients for sarcoidosis, they may ask you, do you have any tattoos? Do you have any scars? And sort of these are the areas where we expect that we might be able to detect subtle presentations of cutaneous sarcoidosis. And so your dermatologist may push on these areas or palpate these areas to try to detect that inflammation. There are other presentations of sarcoidosis. So this is an example we call subcutaneous or deep sarcoidosis. And this is where it's less of a rash and it's more of these deeper lumps and bumps underneath the skin. And so this is a very distinct pattern. It has important treatment implications. So as you might imagine, being way down in the skin, if we're putting a cream or an ointment on this to try to treat it, we might not really expect much in the way of improvement as if we were treating a more superficial or close to the surface presentation in the skin. Those are the most common presentations of cutaneous sarcoidosis. But again, sarcoidosis is a great mimicker in the skin. And so you can see listed here a number of other possible manifestations of sarcoidosis, which a lot of this is sort of medical jargon, but they can be sort of these thinning lesions, atrophic, alopecia, which means hair loss, where you can get these patches of hair loss. Most patients with sarcoidosis do not have this, thankfully, and diffuse hair thinning is not a presentation of that. Sometimes you can get finger or toenail changes. These are also pretty uncommon. And these other, again, medical jargon terms here, just referring to the different ways that sarcoidosis may look in the clinic. But what unifies these as being sarcoidosis in the skin is that when a biopsy is performed, and I'll talk about biopsies shortly, we actually see those granulomas in the skin. So we see granulomas despite what the under the microscope, despite what the rash may look like, to the plain eye. As I mentioned earlier, it's also important to note that many patients that have rashes or other skin changes are not due to sarcoidosis. And so really making that distinction is an important one. So what do you do if you think you might have sarcoidosis in your skin? Well, I would argue it's really important to see a dermatologist. Dermatologists are trained to recognize and diagnose sarcoidosis in the skin, even if it's a non-classic or one of those unusual presentations. We're trained sort of what to look for. Believe it or not, it may matter where you actually see a dermatologist. So for folks that are looking to establish care, university-affiliated dermatology practices in your area are the best bet. These are dermatologists that are trained to and actively see patients with sort of these less common inflammatory dermatology problems. There are other places which maybe aren't as well equipped. And so I'd encourage you to seek care at one of these places. Access to dermatologic care is a big problem. And as people on this call probably realize, that weight problems can really be an issue. And although there's no perfect way to overcome this, there are strategies that can be helpful. Asking your primary care physician or referring provider to facilitate getting you in sooner. Ask if you can be called in the event of another patient's cancellation. This is often a really, really good strategy. And if you have flexibility in your schedule, it can be a way that you can actually get in rather quickly to see a dermatologist. And, medical offices are stressed these days, and patients often have a lot of frustration at trying to get in. But I will say that as much as you can sort of be, pleasant and advocating for yourself on the phone, it can really go a long way, and you may stand out for better or worse from other patients in the same situation. And so my main point here is that seeing a dermatologist at in a university setting really is ideal when possible. And it just helps to try to be proactive, because there are problems with access. And so what to expect when you're actually seeing a dermatologist? Well, you really should expect a very thorough skin examination if you're comfortable with it. This includes examination of your hair, your nails, mucous membranes, meaning eyes and mouth. A skin biopsy is customary to confirm the diagnosis of sarcoidosis if it's expected. I find a lot of patients that I've spoken with are sometimes frustrated that they go to see a dermatologist and they're worried they have sarcoidosis in their skin. And the dermatologist looks at their skin and says, oh, no, that's not sarcoidosis. And so, this is obviously a complex issue, but despite being this great mimicker that can look a lot of different ways, dermatologists often can exclude cutaneous or skin involvement of your sarcoidosis just by looking at your skin. If there is a suspicion that you may have sarcoidosis, a biopsy, a skin biopsy is typically performed, and I'll talk about that on the next slide. Rarely or occasionally, a skin biopsy may not be performed. If your rash looks like sarcoidosis to a dermatologist, if you already have a diagnosis of sarcoidosis in other organs, it may not be biopsied under those circumstances. What to expect with the skin biopsy? These are quick, they're relatively non-invasive. What the area would be cleaned, it's anesthetized or numbed with a local injection, just like you're going to the dentist. And there are two different types of biopsies that are performed mostly within dermatology. One is called a shave biopsy, where you take a little slice of the skin very close to the surface. The other type of biopsy is called a punch biopsy. That's where you take a little core that looks like a little cookie cutter that's about the size of a pencil, and you actually go down into the skin to sample a little bit deeper. We know that the inflammation in sarcoidosis actually usually is a little bit deeper down. And so a punch biopsy is the preferred method. While a shave biopsy may be able to diagnose sarcoidosis, we know from experience that occasionally it can miss it because it doesn't sample down deep enough. And so really this punch biopsy is the preferred method. It may require one stitch. Sometimes providers will use a packing material instead. Both are totally fine. Healing typically takes about a week or so, and the biopsy results usually come back in about a week. So I just wanted to first address, so let's say you're a patient that has sarcoidosis and you're worried you have sarcoidosis, and you go to see a dermatologist and they do a biopsy, or maybe they just look at your skin and don't do a biopsy, and they think that it's not sarcoidosis. Well, what you really should do, because we don't encounter this uncommonly, is one, make sure that you understand the diagnosis. There may be a variety of different treatment options depending on the sort of severity of your disease or other factors. And interestingly enough, sometimes treatment for sarcoidosis, say maybe sarcoidosis in your lungs, may help the skin, even if the diagnosis is not sarcoidosis. And so it's important to ask your doctor, your provider questions like, do you think this treatment for my pulmonary sarcoidosis might also help my skin? Or do you think this treatment for my pulmonary sarcoidosis might not affect my skin, or maybe even potentially worsen my skin? These are really good questions to ask. Other times, the skin will require specific therapy that's different from your sarcoidosis therapy if you want to treat it. And in sarcoidosis, and this is something that I'll reiterate throughout the session, it's really important to make sure your doctors are talking to each other. So now let's go to this scenario that my rash is sarcoidosis, but this is the first time I've been diagnosed with sarcoidosis. So this is a brand new diagnosis. Occasionally sarcoidosis only involves the skin, but more often than not, other organs are also involved. And so evaluation for sarcoidosis in other organs is really important. And this is something that you can work with your dermatologist, your primary care provider on, Usually the lungs, the heart, the eyes are evaluated whether or not you have symptoms. And depending on any other symptoms that you may have additional testing or see other specialists. And so it's important to just sort of keep in mind that sarcoidosis in the skin may reveal that there may be sarcoidosis in other organs. Alternatively, you may find out that you have cutaneous sarcoidosis, but you already knew that you had sarcoidosis somewhere else in your body. So we get that confirmation in the diagnosis. So, treatment for the skin and other organs are often the same, but not always. And so having seen a lot of patients, over time with cutaneous sarcoidosis, I find that it's really important to clearly communicate, first of all, your desire to treat your skin. Patients that are seeing a pulmonologist or a cardiologist may be really focused, and rightly so, on their lung or their heart involvement by sarcoidosis, and may assume that perhaps the skin is not as bothersome to the patient. And so I think it's just important to communicate that. Do you want treatment for your skin? Does it bother you? And then it's also important to go a step further and say, well, what is it about the skin that bothers you? Is it the way that it looks? Are you having symptoms? Is it something else, or sort of a combination of things that are making you interested in seeking therapy? And again, it's really important to encourage your doctors to communicate with each other. What are the motivating factors for treatment? Is there primary lesion? The primary reason, we have a lot of patients that their lungs actually don't need treatment, and they're a motivating factor to try to treat their skin. And that drives things in a certain direction. Other times, the lungs really need to be treated, and we want to find something that also has a high likelihood of benefiting the skin. And so just making sure that people are communicating and everyone's on the same page. So in the last couple of minutes, and then I'd love to open up to a Q&A, because I think that will be the most fun part of this evening. But let's just talk about sarcoidosis treatment. And so when we approach really treatment of any inflammatory skin disease, we often talk about this so-called treatment pyramid. And what that means is that we may start with treatments or therapies that may be less potent or less effective, but have very little or no safety concerns. And if patients respond to that, great. If they don't respond to that, we move up the pyramid. And as we go up the pyramid, the strength or the potency of the medications tends to increase, but also do the potential side effects. This may be more worry on the patient. This may mean there may be more lab monitoring or more frequent follow-up visits. But this is sort of the paradigm which we think about treatment of skin sarcoidosis and other inflammatory skin disease. And so the question is, where do you start? Historically, we started at the bottom. Increasingly, we think about starting anywhere in the treatment pyramid, depending on the patient. And so again, what are the motivations for treatment? Are we treating the lungs? Are we treating the skin? Are we treating both? Are we treating something else? How extensive or severe is the skin involvement? What areas are involved? The upper arm may be different from the nose. Is scarring present or developing? What's the pattern of skin involvement? What other medical problems does the individual patient have, if any? And what's the patient's level of comfort with the adverse effect profile of a particular medication? And so this obviously is not a one-size-fits-all thing. And these are very nuanced discussions. And I would say that, a patient may come in with sarcoidosis on their skin that may be the exact same or very similar lesion or rash, and they may approach it very, very differently. Some patients may say, gosh, I'm really reassured to know this is just my sarcoidosis. This is not really bothering me that much right now. My main motivation is to get my lungs under control. Let's just see what happens. Other patients may come in and be very distressed by their skin, and that may be their driving motivation, at least from their personal level, for treatment. And there's really no right or wrong answer, but we as doctors need to, do our job to sort of help each patient navigate that path. So what are the treatments that we use for sarcoidosis? Well, creams and ointments are kind of the first line therapy. So steroids, a lot of people in the audience are probably familiar with prednisone, which is an oral steroid. There are also topical steroids, which are built into creams and ointments. There's another class of medications called calcineurin inhibitors. There's also other ones. These are good for mild involvement of the skin. They're not generally terribly effective, and I'd be happy to talk about that a little bit more during the Q&A, but they're safe, they go on the skin, and so there's really low risk associated with trying these. I wanted to just take a brief pause and just talk about treatment response kinetics, or the speed of improvement in patients with sarcoidosis. And so typically we as physicians think that even with effective therapy, sarcoidosis in the skin as well as elsewhere can be slow to respond, meaning it just takes a long time to see improvement, even if you're on the right medicine. And we're taught that that may be from 3 to 6 months. Sometimes this is not really communicated well by doctors. And so as a physician that's treated a lot of patients with sarcoidosis, I think it's really important to try to clarify that and ask questions like, how long will I be on this before I try something else? Or additionally, it's also important to communicate very specifically what bothers you about the sarcoidosis in your skin. Because sometimes the patient's expectations for what qualifies as improvement are actually very different from what the doctor's expectations are and what the doctor would judge as improvement in the skin. And I think this is kind of the elephant in the room, because there's often a big disconnect in terms of what the patient's expectation is and what the doctor sort of might expect over time. And I really find it's just so helpful to say specifically, X bothers me about having sarcoidosis in the skin, whether it's a swelling, whether it's the itch, whether it's the dark marks. And when a doctor is recommending a therapy for you, it's really important to recommend, or to ask, do you think this therapy will help with X? Whether it's, again, itch, pain, redness, raisedness, scarring, because any particular therapy may or may not address those things. And I think it's just really just so critical to establish what the patient's goals are and what the metrics of success are. Okay, I spent a little bit longer on that than I wanted to, but I think it's really important. I'll try to wrap up here in about 3 minutes because I really want to have the Q&A. So intralesional or injected steroids, so these are steroid medications that are injected right into the spot, are commonly used in sarcoidosis. They're good of the skin. They're good if you just have a few spots or if you have a few deep spots. But, if you have spots all over the place, chasing them with injections in each spot is, 1, uncomfortable, and 2, really just untenable. But in some patients, this can be effective. So when we've talked about creams, we've talked about injecting medicines right into the skin. If those things aren't effective, typically we'll go on to medicines that work from the inside out. And I think of these as sort of a few different classes as we move up the pyramid. So in the skin, not as much in lungs or other organs. Sometimes antibiotics are used. In general, this is not an infection. And so most of the time, antibiotics do not help. Sometimes they may. Hydroxychloroquine or Plaquenil is another medication that's often used in the skin for sarcoidosis, less so elsewhere. I do have a number of patients on hydroxychloroquine, some which are doing okay. I think the important thing to recognize as doctors and patients about hydroxychloroquine is that, and to put it in baseball terminology, when we're talking about effective treatment, it's effective as a base hit or maybe a double at best. We're not talking about a home run. So oftentimes patients will come back and their doctor will be so excited because maybe the lesions aren't raised, or maybe they're a little less red, but really the patient just wants everything gone. And so this just comes back to this idea of, what's the patient comfortable in terms of side effects? What are their expectations? And just being on the same page with your doctor about those expectations. Towards the top of the pyramid are stronger medications that work from the inside out. So some of these may look familiar, some may not. Methotrexate, thalidomide, TNF-alpha inhibitors, prednisone. In general, I put prednisone in red because it's a medication that so many patients with sarcoidosis are familiar with. We don't use it that much in dermatology because we find that, patients may improve in the short term, but in the long term, when we stop the medicine, the rash may just come back. My own personal group's research works with this class of medications called JAK inhibitors. And I hope we'll get maybe more into this during the Q&A section, but really which systemic medication, if a systemic medication is pursued, is best for you is really a complex discussion. Hopefully I want to make sure we get through the talk so we have time for the Q&A. So I hope to kind of come back to that. But the one last point that I want to make is that, experienced dermatologists, experienced physicians in other specialties may know when you don't need to do the first couple steps of the pyramid. They may know based on the severity, the extent, the areas involved that these things at the bottom of the pyramid probably aren't going to work. And really, to get your disease under control, we may need to start higher up in the pyramid, and that's okay. So in summary, treatment for cutaneous sarcoidosis can be effective. It may take trial and error. So what works for one patient may not work for another. It's frustrating for us as doctors too. The trial or, sort of trying phase of the medicine may be longer than you like, about 3 or 6 months. And again, that's also frustrating for us too. We need to make sure to have a holistic approach where we're talking with pulmonologists, PCPs, cardiologists, other doctors, making sure everyone's on board with the treatment. And it's really important to set expectations, define what bothers you about the disease in really concrete terms, and what treatment success looks like so that we're all on the same page. So I'm actually not going to spend really any time on the last several slides of the talk because I want to open up to the Q&A. But I would just like in maybe the closing 2 minutes to give you a little sense of where we're going. So the only FDA-approved therapy for sarcoidosis is prednisone. There are no FDA-approved therapies for skin sarcoidosis or sarcoidosis in other organs. Everything else we use is what's called off-label. So it's approved for something else, but we're using it to treat sarcoidosis. And really, this is why FSR is just so amazing and great, is because the research that they support and spur and the collaboration that they engender is really where we need to be going. So we better understand disease pathogenesis and where to treat the disease. We need well-designed clinical trials. It's easy to put these things up on a slide. It's actually very difficult to make them happen, although it's not impossible. And rather than talk about my group's research in sarcoidosis, I want to actually just show you a couple links here, which talk about this work in varying levels of detail. And so I am a dermatologist. I'm also trained as an immunologist, and we're interested in using our group in using this class of medications called JAK inhibitors, which are FDA approved for other indications, but we found can be very effective in sarcoidosis of the skin, as well as sarcoidosis in other organs. And so just in the interest of time, I want to give you these 2 links here. One is the FSR Sarc Fighter podcast. There's an interview with me on episode 39. This is a very sort of high level, easy to digest overview of some of our work. It's a little bit outdated at this point, but it does have a lot of the key concepts. If anyone's interested in sort of a more detailed, nitty-gritty, like figures, biomedicine, here's really the details of what we're thinking. I recently presented a lot of our research, and that's available on YouTube. You can find it through searching this way or through the QR code here. So I'll just leave that up there for a second. And with that, I'd like to wrap up and really would be glad to start the Q&A period.
Great. Thank you so much, Dr. Damsky. That was amazing. We do have a lot of questions already. We also have questions that were submitted in advance at the registration time. I'm happy to dig in with some of the questions that we have. So we do have a question about medications for systemic sarcoid seem to be sort of trial and error. This person has been on just about all of them. Do you have any sort of suggestions in terms of what to do in that case? I know you talked a bit about that in your pyramid, but maybe suggestions around like how to have that conversation with your provider.
Yeah, it's a really super question. So I think, for a lot of these situations, the details are really important. And so, what organs are involved, what's the severity, what are the other medical problems, what treatments have been tried. But that aside, I think it's I would encourage all patients to really have a very I'm not sure if the right word is basic, but a very human conversation with their doctors. Like, this problem is really affecting me in this way. I've tried X, Y, Z. There may be many more than that. And again, I think it's really helpful to communicate the specific problem or symptoms that are, again, motivators for you to try to treat the disease. And I haven't noticed any improvement. And just ask, what's your comfort level in continuing to pursue this with me? Do you think that maybe I should see someone else? I think these are difficult conversations to have, but in my experience, putting it in as like simple and human terms as possible are the best. I hope that helps somewhat.
Yeah, I think so. Thank you. So this actually kind of goes to your question in terms of, I know that you talked about it, people may not treat it at all, but is there a pressing reason to treat skin sarcoidosis if it's not bothering the patient? We did have a couple questions sort of kind of in this group submitted in advance in terms of if you have skin sarcoidosis, can it spread to more areas of your body? Yeah, so I'm not sure if that helps with that question.
No, that's super. That's a really great question. The simple answer is no, you don't need to treat it. So I'll back that up by saying a few different things. One is that we don't have good evidence that if you're on treatment, if you're on effective treatment for your skin sarcoidosis and you have control over it, we don't have any evidence really, unfortunately, to suggest that that affects the long-term course of your disease. And so if your sarcoidosis does not bother you on your skin, you do not need to treat it. That's different though than other organs. And so, if you have sarcoidosis in your lungs and even though it may not be bothering you, if your pulmonologist feels strongly that it's severe enough that it requires treatment, there I think the conversation is very different. But as far as we know, controlling the skin does not affect the long-term prognosis or natural history of the disease. And in terms of spreading, unfortunately, this is not just sarcoidosis. This is a lot of inflammatory skin diseases, a lot of inflammatory diseases in other organs. We unfortunately just don't have good predictors of what the long-term prognosis is going to be. So, who's going to have sarcoidosis for 2 years, like you might read online, and then it goes away by itself? Who's going to have sarcoidosis that's really going to march through this progression over time? We just don't have good predictors of that. And it's something that as a medical community, we really need to work on so that we can have, more concrete counseling of our patients about what might be required. But anyways, to simply answer the question, if you have sarcoidosis on your skin and it doesn't bother you, that's fine. You can leave it alone.
Thank you. So we have a question about Humira in terms of, it seems like it's an effective treatment. What happens if your body develops or what happens if, or can they develop antibodies for the biological and it's no longer effective?
Yeah. So that goes for all TNF alpha inhibitors. So Humira, adalimumab, Remicade, or infliximab. There's other ones too. In general, infliximab or Remicade is the one that has the highest propensity for development of antibodies. So for those that may not be familiar, these medications, these TNF alpha blockers, are actually antibodies themselves. And so they are injected into your body or your bloodstream, and they go around and they neutralize this protein called TNF alpha. So those antibodies themselves, or which are foreign proteins, your body can actually develop a response to and stop them from working. And so in, a really classic example of this, you're on one of these medications, your sarcoidosis gets way better, but suddenly it stops working. And that may be because your body's developed an antibody, which is actually neutralizing that other antibody or drug and preventing it from working. There are tests for these things. I think it's really important for doctors to be thinking about. Also, there are ways to measure blood levels of these drugs, and there are data in other diseases that suggest the blood levels of these different medications are important. And this comes back to the idea of that, sort of dosing being important. And so there's not really a perfect solution to this problem. I think it's just something as a patient, certainly as a doctor or provider, that we always need to kind of have on our radar. It's the possibility that this medicine, which was once effective, it is no longer effective. And ultimately, it means it's time for a switch.
Thank you. In talking about TNF treatments again, we have someone who says they're on TNF treatment for cardiac sarcoidosis. How often can an anti-TNF treatment for cardiac sarcoidosis also manifest in psoriatic skin issues? Can these issues mask skin sarcoid?
Yeah, so this is really complicated, and it's a great point. So for reasons that aren't fully understood, this class of medications, these TNF alpha blockers, in general, they make sarcoidosis better. Very, very rarely, they can trigger sarcoidosis, or they can trigger psoriasis. Much more commonly, they trigger psoriasis or a psoriasis-like skin eruption. And so I think that the answer to your question is that it's conceivable or possible that the TNF alpha blocker that you're taking may have triggered psoriasis or a psoriasis-like reaction in the skin. And it's a bit I guess sort of complex exactly what to do about that. It depends on a number of different things, but in general, we think that switching to a different TNF blocker is usually the best first step, and we'd expect that some patients would have improvement in their skin on a different TNF blocker. So I guess I would say it's possible that the TNF blocker is actually causing that reaction in the skin. It's something we see not uncommonly.
Thank you. So we got a lot of questions on this, and I know you did touch on this. I'm going to bring it up for everybody on the webinar anyway. Yeah. If you don't have sarcoidosis in internal organs right now, and you only have skin sarcoidosis, can it move to the internal organs, or can it develop in the internal organs? And I know you talked about this a little bit, what should you watch for in terms of making sure that you're getting the checks that you need?
Yeah, that's a really great question. And it comes back in part to this idea that, unfortunately, in medicine, and this is not only in sarcoidosis, we just don't have good biomarkers or other markers for prognosis. So there's not like a blood test we can order that says you have X likelihood of the sarcoidosis spreading to your lungs or your heart. I will say, though, that in general, patients that have isolated cutaneous sarcoidosis, in my experience, that's the initial presenting organ, or the organ that is involved. Patients have a workup and we don't find it anywhere else. And, those patients tend to remain skin only. But there is some risk that it may, involve other organs, and whether it was always there and just kind of smoldering under the radar, or whether it's, quote unquote spread, I think is harder to say. But in my patients that have skin only sarcoidosis or sarcoidosis otherwise, the main questions that I ask them are about their eyes. We know that sarcoidosis can affect the eyes. So symptoms like itching, symptoms like vision changes, pain, other things like that, we often talk about quite a bit to make sure they're not having involvement of the lungs. So cough, shortness of breath, fatigue, tired, trouble with exercising. These are important things. And then the heart. So palpitations, or feeling like the heart is beating quickly or skipping a beat, or, lightheadedness, or either passing out or even passing out. And these are all symptoms which suggest that there could be sarcoidosis. Not that there is, but there could be sarcoidosis somewhere else in the body. And then we would need to do the testing. So I guess what I would say as general advice is that, just keep your physician posted with things that are new or changing, or you have questions about.
Thank you. So we have two questions actually about Plaquenil. One is itching on your arms really bad when you take it, a side effect? And then the second question we have on Plaquenil, does it lose effectiveness over time?
Good questions. So the itching on the arms, I wouldn't say is a classic effect of Plaquenil, but I hope it's helpful to say that, any medication in any person can cause really just about any problem. And so if you really have a strong suspicion that starting Plaquenil, caused this itching on the arms, I think it's important to convey that information to the doctor that's prescribing it. And depending on the clinical situation, maybe trying a few months off of the medication to see if it resolves. It's also, helpful just to talk about those symptoms in general, and maybe potentially other causes, because we, as dermatologists, we do see a lot of patients with itchy skin. So that was the first part. The second part was Plaquenil and loss of efficacy. It's a hard question to answer sort of universally. I would say it's conceivable. In my patients that take Plaquenil for their sarcoidosis or hydroxychloroquine, I'd say that usually the response is durable over time. So it's sort of the same level of control over time. However, we know that for unclear reasons, your sarcoidosis may decide that it's going to ramp things up a little bit. And so it's possible that the sort of magnitude or level of your sarcoidosis has changed over time for reasons that are, not fully clear or explainable, and that whereas hydroxychloroquine was once effective or enough, it may unfortunately not be anymore. But again, I think this is, comes back to this idea of really just if you notice a change, there's probably something to it, and it's important to discuss what you're noticing with your physicians.
Thank you for that. We did have one other question about Plaquenil.
Yeah, sure.
Is it also used for other manifestations of sarcoidosis, or just the skin?
I'd say it's probably most commonly used in the skin. Sometimes for ophthalmologic or eye involvement, it can be used. I've seen it less used for pulmonary involvement or lung involvement. I've seen it less used for cardiac involvement. I think some of these other organs, particularly the heart, the stakes are high, and so or potentially high. And so I think that, the treating physicians often go for, quote unquote, stronger medications than Plaquenil. I think that's why it's common in the skin, and maybe why antibiotics are used for some patients, because, the stakes aren't quite as high. If we can get you in a good place with these less, strong medications, then, we have the flexibility to look at that.
Thank you. So we have a question about, can granulomas sort of occur deep in the skin, cause sort of a bone to protrude, or be near smaller joints? And if yes, who is the best type of doctor to assess that? Is that a dermatology, rheumatology, orthopedic?
Mhm. Yeah, I'd say that dermatology and rheumatology would probably be good places to start. Um, it depends a little bit on exactly what is happening. So we know that sarcoidosis can involve deep layers of the skin. So it's like this kind of like semi-firm, softish, almost feels like a grape under the skin that you can kind of, move around. That would be more skin involvement. Patients with sarcoidosis sometimes can have other autoimmune problems like rheumatoid arthritis, where they might develop like a rheumatoid nodule, for example, and that's dealt with a little bit differently. So I think I'd probably start with dermatology or rheumatology. And if they had the suspicion that it might be deeper down in the skin, that they might not be able to get you a diagnosis with a biopsy, they might suggest an imaging study like an ultrasound or, maybe even a CAT scan or MRI. And depending on the findings, might have you see something like orthopedics.
Great, thank you. So we have another question about sort of systemic sarcoidosis. If you're on Imuron, is it Imuron?
Yep, Imuron, yep.
Both cover skin sarc as well, if you're on it for other manifestations.
Yeah, I mean, so I guess I would say, so Imuran is a medicine that affects T cells, which are an important part of the immune system and are thought to be really the main drivers of sarcoidosis that are activating this other cell type called macrophages. And so as far as we know, sarcoidosis in the skin, the lung, the heart, the bone, they're all, the signals that are leading to inflammation in those organs is all the same. So when you think about it at like an intellectual level, you'd say Imuran's treating sarcoidosis in, organ X, the lungs. It should also treat sarcoidosis in organ Y, the skin, for example. And sometimes it does, and sometimes it doesn't. And why that is also not fully clear. And so I would say that after a good trial of 3, certainly 6 months of Imuran, if you had not noticed improvement in your skin, I think it's fair to say that it's probably not going to work for it or work well for it. What makes this complicated is sometimes the other organs that the Imuran is being used for are actually responding really well. And so it becomes sort of a complicated, nuanced discussion of what the best path forward is, because of course we don't want to lose the response in one organ for another organ. So sarcoidosis is a disease that doesn't always read the textbooks or follow the rules, and so it's a lot of this stuff is on a case-by-case basis. But I think to just simply answer the question, it's very possible that sarcoidosis might work for your lungs or another organ, but not work for your skin.
Thank you. After taking medication and it clears, do you need to continue to take the medication, or if it stopped, will it come back?
Yeah, this is a super question. And this is a question I often get asked by doctors too. So sarcoidosis is a disease that we know. I mean, a lot of patients, when they're diagnosed, they maybe go online or they're told by their doctors. Like a lot of time, this doesn't require treatment and it'll just go away on its own. So that's kind of unique. We know, of course, that some patients, unfortunately, are chronically affected and have progressive disease. And again, we don't have a great way to tell who's going to be who from the start. One of the things that we're really interested in my research group, and others are interested in this too, is how do specific medical therapies affect the natural history of the disease? So if we were to, treat aggressively up front and control the sarcoidosis, does that lead to an increased likelihood that it's going to go away on its own, that it's not going to cause problems down the road? And unfortunately, we don't have really good data on that, but it's something that we're hoping to understand as the years go on. So I guess I'll just say, when we're thinking about approaching patients from the skin perspective, our first goal is to get the disease under control. So we want to make your skin clear, and we want to keep it clear for a period of time. So usually that's about 6 to 12 months that we want to keep it clear for. If patients are clear with no evidence of any activity, we'll often have a discussion of, well, let's try spacing out the medicine. let's try going down on the dose and we'll see what happens. I would say that it's hard to put exact numbers on it, but maybe a quarter of patients are able to taper down and ultimately off therapy. A majority of patients are will have some disease recurrence as they try to taper down and need to come back up. And we also have, being at a major academic medical center, we often end up seeing patients with very severe sarcoidosis. And so that statistic that we're seeing in our clinic may not be, representative of patients as a whole. So it's a really great question. We're trying to get research funding to answer that question. And I think there are compelling reasons to think if we're using the right treatment, it may alter the long-term course of the disease, but we just don't know yet.
Thank you. So we have time for just a couple more questions. One of them is, if Remicade stops working, can you switch to Humira?
Yeah.
Is that a good?
Yeah. Yep. That would be good. And, thankfully we have a number of these TNF alpha medications now. And so there are, again, we touched on this earlier, there are tests to see if you actually have developed neutralizing antibodies to the drugs. And so I would encourage you to ask your physician to check those if they've not. If you stopped responding and you don't have drug neutralizing antibodies or medication neutralizing antibodies, it may suggest just, underlying progression of the disease. But if you do have those neutralizing antibodies, then yeah, of course, switch to another class, and we would generally expect the same effect from that different medication.
Thank you. Okay, guys, so our final question actually came from previously submitted at the time of registration. And that question is, what is the future of skin sarcoidosis research? Is there anything on the horizon? Are we looking forward to anything potentially being reused or coming onto the market for skin sarcoidosis?
Yeah, it's a great question. So I think I would say, and this is a great place to close on, that there are a lot of reasons to be really excited, or not excited, but to be cautiously optimistic about the future. One is that there are now, through FSR and other groups, there's really a lot of great research happening in sarcoidosis now, where we're applying techniques that are new and have never been applied to sarcoidosis before. And I'd say really can revolutionize our understanding of this disease. And along with that comes, novel, the opportunity for novel or new therapeutic intervention. And something that our group has employed is a class of medication called JAK inhibitors, JAK, which refers to a specific protein in the body. And we've really observed remarkable efficacy through those class of medications. And the links that I put up before discuss that a little bit further. And so we're in the process now. We just had a very successful clinical trial in cutaneous and systemic sarcoidosis with one class of those medications. And we're just about to start a follow-up trial where we really hope to pursue this exciting avenue of investigation. In addition to that, we're working on a paper right now where we're describing all the clinical trials that are happening in sarcoidosis. And there's just so much happening. There's just so many targeted drugs that people are thinking about now. There's a lot of interest in this disease. And so I think, the next several years, we're really going to see a shift towards improved understanding, increased awareness, and ultimately more effective therapies.
Wow. Thank you for that. That is an excellent way to end the webinar. We really appreciate all of your insight and your expertise. I am going to just close this webinar out. So thank you so much for that. I'm going to share this last slide with folks because my usual plea for people, please filling out the survey. So as a reminder, we do value each and every one of your feedback and about our webinar. So please complete the super quick survey. I promise it's quick. For those of you using Zoom in a browser, it should automatically take you there once you leave the webinar. If not, I will add this to the chat. I also want to remind folks that we have more educational wellness webinars before the end of the year. You can sign up by going to stopsarcoidosis.org/events. And if you haven't already, please join the FSR community. Stay up to date on news, events, and clinical trial opportunities. And we are also excited to share new opportunities to make a difference in the sarcoidosis space. We are currently looking for volunteer community outreach leaders, including at Dr. Damsky's hospital at Yale, to work with our sarcoidosis clinic, our Global Sarcoidosis Clinic Alliance, and the 38 Clinic Alliance members we have across the country. So you can actually learn more about the unique opportunities to make a difference and to get involved with FSR by visiting our website and the link that I'm going to put in the chat. Also, all patients can take research into your own hands by joining the FSR patient registry, where your voice matters and helps us and researchers understand this disease. We're also calling on all African Americans to complete our Act Now survey, where you can share your experiences with sarcoidosis, as well as your knowledge and perspectives on clinical trials and the role it plays in advancing treatment for sarcoidosis patients. Make sure to click on the survey link before November 29th. All of this is on our website as well. And finally, I must also thank our donors for the continued support of FSR. We cannot provide programming such as this webinar without support. Our generous donors, if you would like to help us ensure this kind of programming remains free of charge for all patients and their supporters, we hope you consider supporting FSR. We have a variety of ways to show your support, and you can find out more via our website. So with that, I'm going to add these links into the chat. And again, I thank everybody for attending today, and I thank Dr. Damsky for attending and sharing this wealth of information with us. We really appreciate it, and I hope everyone has an amazing evening.